So good morning, one and all. And on the second day of our coagulation workshop lecture series, we have lectures on approach to platelet function disorders, VWD diagnosis and management, and inhibitor screening and detection. So we start with the first lecture for today by Dr. Bipin Kulkarni on approach to platelet function disorders.
Thank you, Rucha. And good morning to everyone. The first lecture we start with the platelet function disorders and how to do the laboratory diagnosis and interpretations of the platelet function disorders. So as we saw this in yesterday, just a brief brush up, the primary hemostasis, formation of platelet plug, what are the three major steps there? That is the platelet adherence, platelet secretion, and platelet aggregation. This also we saw yesterday, just the briefly we'll run through. This is the primary hemostatic plug formation where what are the components, major parts involved here is the glycoprotein receptors, the interaction of GP1B95 with the von Willebrand factor, then interaction of the GP2B3A with fibrinogen and other platelets, thereby forming aggregates of platelets. Secretions happening through the platelet granules. So these are the major steps of the primary platelet plug formation, and these are important when we later on come down to the diagnosis of the disorders. So, so this is briefly the platelet structure and the major components of the platelets. The platelets, as we know, are anuclear, but they have organelles like the mitochondria and ribosomes. And the cytoskeleton and the membrane structures are highly complex, and they contain the alpha granules and the dense granules. Now, apart from the granules, which contain the clotting factors and the substances which are required for bringing about activation, that is the ADP, ATPs. The other important structures are the platelet membrane, the transmembrane glycoprotein receptors. Now, these receptors are in an inactive state in resting platelets, and they have to be activated for them to be open for their ligand binding. And each receptor, they have their different dedicated ligands and through which they operate. So the GP1B95 complex, as we saw, it binds to von Willebrand factor majorly, which is immobilized on the subendothelial collagen. The GP1A2A, that is it binds to collagen. It's a collagen receptor. GP6 is also a collagen receptor, and GP2B3A, that is the receptor for fibrinogen and von Willebrand factor. So this brings about the GP2B3A brings about the aggregation. Now these are the contents of the granules. The alpha granules mainly contain the clotting factors, fibrinogen factor 5, factor 8, and these are the functions which are mentioned. Now, as we saw yesterday, the PDGF, platelet-derived growth factor, which is required later on for the vessel repair, that also is contained in the alpha granules. Then the von Willebrand factor, the antiplasmin, which is plasmin inhibitor, some of the clotting factors like the high molecular weight kininogens, and also fibronectin, which is there in the alpha granules. Whereas the dense granules, they contain the ATP, ADP, calcium, serotonin, which is these are platelet agonists, and they regulate the platelet activation, and also the they promote the vasoconstriction, which is required in the just before the primary hemostasis kicks in. Then the lysosomes, which have proteolytic and hydrolytic enzymes, they help in to digest the vessel wall matrix and the debris later on. Now these are the major receptor complexes, and on the right hand side are the receptor ligands and their functions. Now, for the platelet activation, the major steps here involved are adhesion, secretion, and aggregation. Now, what happens in each of the steps? Platelet adhesion is the adhesion of the GP1B95 complex receptor, which binds to the von Willebrand factor that is immobilized on the subendothelial collagen. So that is the adhesion. Also, the platelets bind to the collagen through the collagen receptors directly, that is the GP6 and GP1A2A. Then the next step is secretion. Secretion takes place through the secretory granules, the alpha granules and the dense granules. So the alpha granules that contain the clotting factors and the dense granules, the ATP and ADP, through which the secretion happens. The thromboxane is also secreted. And the last step is aggregation, where the platelets, they activate the activated platelets, they change the conformation, and the GP2B3A mediated aggregation takes place via the cross-linking molecule of fibrinogen. Now, what could be the disorders in hemostasis? Now, the disorders could be vascular, that is in scurvy, like that is the formation of the blood vessels themselves, where the collagen tissue is not well formed and there could be leakage of blood, and that could be the vascular disorders leading to easy bruisability and other bleeding complications. Then comes the platelet disorders. Now, what kind of platelet disorders? It could be the disorder of number or function. So, low platelet numbers, thrombocytopenia, or abnormal function. Those are the functional defects. Third is where the disorders can happen is the coagulation disorders. That is hemophilia and a deficiency of other rare bleeding coagulation proteins, factor deficiencies. And the last one is mixed or consumptive coagulopathy. That is very commonly called, the DIC is one of the forms where it is consumptive coagulopathy. It is an acquired form. Now let's look into the inherited platelet function disorders. Now these are hemorrhagic disorders. They are characterized by defective platelet function activation. They may have reduced platelet numbers. Patients may have mild to severe mucocutaneous bleeding manifestations, and there is wide phenotypic and genotypic heterogeneity, which makes it difficult to diagnose and characterize each one of them at the laboratory level. Now, about 41 of these disorders are identified so far. The exact prevalence is not known because of the rarity of most of them, and it is poorly understood and difficult to diagnose at the lab level, as I said, because there is a lot of overlap when it comes to laboratory diagnosis. Now, let's come to the disorders of the platelets, because the focus of today's talk is on platelets. So, the first, the two major problems with platelets is it could be a problem of numbers or it could be a problem of function. So, problem of numbers, it encompasses the decreased production, or it could be decreased survival that happens in ITP, or increased utilization, which happens in DIC. That when it comes to defective platelet function, it could be either acquired or congenital. Now, what are the ways we can study the platelets in the laboratory? Like for the structure, there is electron microscopy, which can help in studying the structure of the platelet. Function can be studied in different ways. Previously, it used to be studied by skin bleeding time, which is now more and more getting obsolete. Aggregation studies are still done. They are very handy and helpful. Platelet aggregation studies in vitro, where we see the response to various agonists, and the assay of secretions can be done in vitro. And of course, flow cytometry is there to look for the activation status and the granular components of the platelets. Now let's look into the qualitative inherited platelet disorders. That is the problem of function. So where could be we saw these three steps: adhesion, secretion, and aggregation. Now where could be the disorders in these? So problem of or disorders of adhesion, they include Bernard-Soulier syndrome, that is the receptor deficiency of GP1B9, which binds to von Willebrand factor. There you can have problem with the adhesion. Then platelet type or pseudo von Willebrand disease, where there is a gain of function mutation in the GP1B again, which because of which there is clearance of the von Willebrand factor. So that also is a problem of adhesion. And then the collagen receptor deficiency, that is the GP6 or other collagen receptor deficiency. Now these are the defects of adhesion. Now when it comes to secretion, obviously since the granules are responsible for secretion, if there is any granule defect, it goes into the secretion defect deficiencies. Like dense granules defects, it is called storage pool deficiency, or the alpha granule deficiency is called gray platelet syndrome. Then of course is the aggregation defect, where the problem is with the GP2B3A receptors, and that disorder is called Glanzmann's thrombasthenia, where the platelets don't aggregate because of a defective formation of GP2B3A receptor. Then comes lastly, which is a very rare condition, but platelet procoagulant activity, like the platelet factor 3, what we saw yesterday, which is called Scott syndrome, which is a very rare phenomena, but the problem is with impaired platelet procoagulant activity. So these could be the qualitative problems and the different areas where they can be located. Now there are several drugs that affect platelet function, and that is the reason when we do platelet function in the laboratory, we have to be very careful not to take random samples, and the sampling has to be by previous appointments. We know what the patient is taking, and we have to record whatever patient is taking, the drugs, what the patient is taking, the physiological condition of the patient, and all the other factors before we take the sample for platelet aggregation. Because platelet aggregation studies, they are very, platelet function is very delicate and can be very easily affected by many things. There is a whole lot of drugs that can affect platelet function. Some of them are mentioned up here. Now, apart from that, not only the drugs, but there are many spices and foodstuff that can affect platelet function. So we even have to keep a record of what the patient has had in his last night dinner. So that can affect the platelet function if he is coming to the next day early morning for sampling for platelet function. So you can get an erroneous platelet function result if depending on what the patient has had the previous night. So as far as possible, we advise the patient to have simple food the previous night, and that morning also. If fasting sample is not possible, if the patient is coming from a far off place, then we tell the patient to have something which is non-spicy and very light food and come as breakfast, and then you come give the sample, and then you can eat whatever you want. Now these are some of the fruits that also are known to have inhibitory effects on platelet function. So one has to be very careful before taking the sample for platelet aggregation and before interpreting any of the results. Now, platelet function is a screening test. It's not a confirmatory test. So you have to keep all this in mind before we do the platelet function and when we give out the interpretations. Now, platelet aggregation testing can be done by using platelet-rich plasma, PRP. So considering that the EDTA platelet count is in the normal range, around 250,000, we collect the citrated blood sample and then centrifuge it at about 700 RPM for 10 to 15 minutes. And then the supernatant platelet-rich plasma is separated out. And then that can be used for platelet aggregation studies by LTA, light transmission aggregometry. Whole blood aggregation can also be done. Either that is also citrated whole blood. It can be done with or without dilution. The impedance aggregometry is there. You can use it for doing whole blood aggregation. Now, acquired platelet function disorders are more common than the hereditary ones. Acquired function disorders could be because of many drugs many other conditions or physiological conditions, disease conditions like myeloproliferative disorders, they can affect the platelet function. So all this has to be kept in mind before doing the platelet function, or at least you have to correlate it while you are giving out the interpretation. Now, how is it done? This is the light transmittance platelet aggregometer that we have in our lab and which is commonly used. Now, the principle is transmittance of light. So there is a photodiode and there is a light source. There is a light detector and a light source. And in between, there is we have to use the a flat bottom glass cuvette, which is siliconized glass cuvette. And in that glass cuvette, the platelet rich plasma is suspended. So because of the evenly suspended platelet rich plasma, at 0 point or at starting point, the transmittance of light is considered as 0% transmittance. And then as we add the agonist into it, and as the platelets start aggregating and clumping, the transmittance of light slowly increases, gradually increases. So from 0, it starts going towards 100, you can say. So here what we keep as reference is the same patient's platelet poor plasma. So that is reference, meaning that is set at 100% transmittance of light. So it considers that same patient's platelet poor plasma as 100% transmittance of light, and then it compares with its own platelet rich plasma. As the platelets aggregate, they move from 0 towards 100. And then how much ever the maximum aggregation happens, the graph plateaus there. So these are the stages or steps that take place during the aggregation. So here in the beginning, we have the normal resting platelets. So when we collect the platelet sample or the PRP, because the platelets have undergone a centrifugation step, you have to rest the platelets for 15-20 minutes on the desk. Let them come to the resting stage, and then you start the aggregation studies. And also the aggregation studies have to be completed within 2 hours of blood collection. Otherwise, the response will start falling down. Now here, as you can see here that the starting point is set at 0% transmittance, and the maximum here is 100%. So this is the point where you add the sample, and it follows the 0 line. You have to see that there is no spontaneous aggregation happening. So you have to let the graph go at 0 for a while, and then before you add the agonist. Now, after you make sure that there is no spontaneous aggregation happening, at this point you add the agonist. It could be ADP, it could be any other agonist, it could be resorcitin sulfate, it could be collagen. You add it, and then what happens is at baseline your platelets are very normal resting stage stable platelets at baseline. Then here, after you add the agonist, the addition happens and the shape change happens here because of in response to the added agonist. Now, in response to the added agonist, you get the primary wave of aggregation here. Now, till this point, there is no granular release. The platelet granules have not released their secretions yet at this, and this response is based on the added agonist. Particularly, this biphasic aggregation is seen in response to ADP. Now, at this point, till here, the aggregation is reversible. So it can go back. If the granular secretions don't come through, this aggregation can go back to the baseline. Now, if there is now at this stage, the granules release their secretions, and then the secondary wave of aggregation comes through. Now, this is an irreversible phase of aggregation, because here the platelets aggregate completely and they cannot be reversed. So this is how a typical aggregation graph looks like. And these are the steps shown in a different picture. So light goes in from here, comes out from here. This is the PRP. Now there is a small Teflon coated magnet that is placed so that the agonists are in micro quantities, microliter quantities, and they have to mix uniformly with all the entire plasma volume. And for that, there is a Teflon coated magnet here, magnetic bead that moves in this cuvette. So the light goes in from here, comes out from here, PRP with magnet, and this is how you see the graph as it progresses and the aggregation happens. Now the second way of doing platelet aggregation is also by impedance method. Here the whole blood is used and the aggregation takes place in response to a current, that is current field that is applied after you add the agonist. So there is a probe that is inserted in the cuvette containing the whole blood sample, and electric current is applied across the electrodes. And after activation by agonist, platelets form a monolayer on these the probes, and the electric resistance, that is the impedance, is proportional to the increasing platelet recruitment at the aggregation sites. So this is, the output is in ohms. So you can use this method also for platelet aggregation. The third way of this is the Lumi aggregometry, which I briefly spoke about yesterday, is used for measurement of aggregation as well as secretion of the dense granules. Now ATP is measured by its reaction with firefly luciferin, which gives out chemiluminescence, and that can be measured. The resulting light emission is detected, amplified, and recorded by the instrument. Now this can be performed by using whole blood or PRP. And it is sensitive to ATP release, because this ATP release is ATP is the substrate for the luciferin enzyme, which gives out fluorescence. Now it is very sensitive measure of platelet activation. So when there is activation, the ATP is released, and that's how it is measured. Now this is a typical diagnostic algorithm for platelet function disorders. So when you have a proband who has mucocutaneous bleeding, first is of course the clinical evaluation, the physical evaluation, which is made by the hematologist. Now the important thing here is the history, as we spoke about it yesterday also. The personal history, family history, the bleeding score, whether the bleeding is significant enough to go for a complete investigation, and in which line, whether the bleeding manifestations is typical of inherited platelet function disorder. Then comes the physical examination, whether the bleeding is also associated with syndromic features like immunodeficiency, hearing loss, or mental retardation, facial dysmorphism, or discoloration, or those kind of things. If all that is normal, then there is no further studies required as far as platelet function is concerned. Now, if you have abnormality there, then you investigate further. The investigation obviously starts with preliminary laboratory investigation, which starts with platelet count and blood smear. If that is normal, I mean the platelet count is normal, then you go for the function disorder. You look for the platelet function disorders. You may either get the common function disorders by doing aggregometry, flow cytometry. If that is not conclusive, then you may have to go for NGS. Now, obviously, if the platelet count is low, then you have to consider thrombocytopenia and treat it accordingly. Now, always along with platelet function goes hand in hand is routine coagulation screening. That always has to be done. Now, that also includes the VWF screening. Obviously, if APDT is deranged, then you have to consider that. Now, if that is normal, then it comes again to the platelet function. It focuses more on platelet function if the screening coagulation is normal. Now, if the screening coagulation is abnormal, then you can consider conditions where you have combined, I mean, a von Willebrand disease where you get APDT and factor VIII also low along with a platelet function disorder. Clotting factor deficiencies, or it could be afibrinogenemia also. Now, these are the various functional defects of platelets and what happens in that. So, von Willebrand disease, that is the defect of adhesion, as we saw, where you have decreased von Willebrand factor. Bernard-Soulier syndrome is a defect of the receptor itself. So the platelets are there is no adherence of von Willebrand factor with the platelets. Glanzmann's thrombasthenia, as we saw, is a defect of aggregation where the GP2B3A is unable to bind to fibrinogen. Storage pool disease is defects of secretion or release. There is a dense granule deficiency and there is no release happening. Hermansky-Pudlak syndrome. Now these are syndromic features also are positive. So there is a problem with the lipid metabolism that causes deficient release of platelet granules. Wiskott-Aldrich syndrome, there is a structural defect in the platelets. The platelets are small in size. Shediac-Higashi syndrome, that is the lack of dense granules and ADP. Gray platelet syndrome is the lack of alpha granules, and the Scott syndrome, as we saw, is the platelet procoagulant defect. Now, this is the diagnostic algorithm for Glanzmann's thrombasthenia. So, initially, what we do is platelet aggregation studies. If the aggregation with response to ADP and collagen is absent or low, with a normal to reduce aggregation with ristocetin, you can consider further workup for Glanzmann's thrombasthenia. Now, ristocetin sulfate aggregation is also could be normal or could be little bit reduced because the agglutination happens after the aggregation, and since the aggregation is affected, you can get mild reduction in the agglutination also. Now, if that is all normal, now clot retraction you may do, may not do. You can directly go for the flow cytometry and look into the GP2B3 receptors straight away after doing aggregation. If there is a suspicion of GT. Now, if that is not the case, then it is unlikely that it could be GT. Then you further go ahead and take the bleeding history. If it is still suggestive of GT, you can still go ahead and do the flow cytometry. Or if flow cytometry is the final thing, if that doesn't say that it is GT, then it could be something else. Now, this is a typical graph, the tracing pattern of, in a case of Glanzmann's thrombasthenia. Here you can see this is the normal tracing pattern with ADP, ristocetin and collagen. And this is where you get no aggregation with ADP, collagen, and a reduced aggregation with ristocetin sulfate. Now, after this, obviously, you have to go ahead and do the flow cytometry to confirm the diagnosis what you have got. Now, this is the picture of flow cytometry. On the left-hand side is the normal control. So you have the GP1B9 and the GP2B3A complex showing the peaks on the right-hand side. Here you can see the GP1B9 on the positive side, whereas there is no positive shift in the GP2B3A. So that confirms the diagnosis of Glanzmann's thrombasthenia. Now, this is the algorithm for Bernard-Soulier syndrome, the deficiency of the GP1B9 receptor. So the platelet aggregation with ADP collagen is normal, but there is a deficiency of ristocetin-induced aggregation. Now, obviously, if that is not the case, then it is not Bernard-Soulier syndrome. If yes, then you look for APDT as well. In fact, APDT factor VIII, because in von Willebrand disease, there is, along with ristocetin-induced aggregation defect, there is also deranged APDT, because the problem in von Willebrand disease is not the receptor, but the von Willebrand factor. And that's why you have to do a APDT also. And if the APDT is normal, factor VIII is normal, then you can suspect that it could be Bernard-Soulier syndrome. If APDT is deranged, factor VIII is low, then you have to go ahead and do the workup for von Willebrand disease. Now, the third step here, which I have circled, it is optional. The mixing studies, you may not go for the mixing study. You can directly go for the flow cytometry. Obviously, a smear, looking into the smear is helpful, because in Bernard-Soulier syndrome, you get giant platelets on smear. If that is the case, it is very likely to be Bernard-Soulier syndrome. Then you can confirm it by flow cytometry. Now, coming to von Willebrand disease. The von Willebrand disease workup in itself is a specialized investigation, because it involves a complete battery of investigations. So platelet aggregation with ristocetin sulfate is absent. The defect is not in the platelets, but in the von Willebrand factor molecule that binds to the GP1B9. Now, there are three types or subtypes of von Willebrand disease. The type 1 von Willebrand, which is a quantitative defect, where there is a mild reduction in the von Willebrand factor, 20 to 50% of the normal. Then type 2, there are again subtypes in type 2, which is a qualitative defect. So we have type 2A, 2B, 2B, and 2N. Now, there are specialized investigations which should be done to subclassify this type 2 von Willebrand disease. In type 2A, there is absence of large von Willebrand multimers with low resuscitin cofactor activity. Now, type 2B is a gain of function defect of the von Willebrand factor. So it enhances the binding to the GP through the GP1B, and there is a rapid clearance of the von Willebrand factor multimers and platelets with a low resuscitin cofactor activity. Now, type 2M is the decreased ability to bind to GP1B and collagen with normal VWF antigen, low cofactor, and they can have normal distribution of the multimers. Now, type 2 Normandy more or less looks like hemophilia, because there is the defect is in binding of von Willebrand factor to factor 8. So there is normal von Willebrand antigen, normal resuscitin cofactor, but there is very low factor 8 levels. And then type 3 is the most severe one. There is absence of von Willebrand factor and leading to severe bleeding tendencies. Then the last one is the platelet type von Willebrand factor. There is no, now here it is called pseudo VWD because it is not, the problem is not with the von Willebrand factor, but it is because of a gain of function defect in the GP1B receptor. Now, just like the difference in type 2B and the pseudo VWD is that in type 2B there is gain of function in von Willebrand factor, whereas in this pseudo VWD the problem is with gain of function mutation in the GP1B, which results in clearance of the von Willebrand factor. Now, this is a schematic of the diagnostic approach to mucocutaneous bleeding with a high clinical suspicion of von Willebrand disease. So, if you have a mucocutaneous bleeding with a high index of suspicion for von Willebrand, you do the standard testing, then von Willebrand resuscitin cofactor, then you do the antigen. If the ratio is less than 0.6, then how you can classify them as type 3 or type 1 or type 1C. These are the defects of production or clearance, where you see very severely low levels of von Willebrand antigen in type 3, whereas in type 1 you have the mild reduction, and type 1C the problem is with the peripheral clearance, because if you do the protein analysis versus the matured protein ratio, if you see, that is change suggesting that there is no problem with the synthesis, but there is a problem with clearance of the von Willebrand from the circulation. Now here, if you see, the multimers are normal. It could be type 2M, or if there is a loss of high molecular weight multimers, then it could be again subdivided into type 2B or type 2A. If the REPA here is normal, and if the resuscitin induced platelet aggregation with low dose is high, or if it is aggregating even with low dose, then it is 2B, because there is rapid clearance happening there. Now, these are the different levels of factors that you may get in relation to the resuscitin cofactor activity levels and the factor 8 level in different subtypes of von Willebrand disease. Now, along with that, we just saw in the table complex inherited disorders, these are not very common disorders, but they are very rare, and they are accompanied by syndromic features generally. So Hermansky-Pudlak syndrome, and it's very difficult. It's mostly clinical diagnosis. At the laboratory level, it is very difficult to diagnose them. But when we do a NGS, you can get, this is because of the mutations in HPS, that is Hermansky-Pudlak syndrome disorder, which encodes proteins that are components of the multi-protein complexes, and you get abnormal biogenesis of lysosomes. And the patients generally have oculocutaneous albinism associated with mild bleeding manifestations. The Shediac-Higashi syndrome, now this also is an autosomal recessive disorder with the defect is in the LIS gene that encodes lysosomal trafficking. Now these patients have features like giant granules, but the most important feature here is the immunodeficiency that comes from neutropenia. The gray platelet syndrome, that is the deficiency of the alpha granule proteins, the platelet factor 4 and the beta thromboglobulin. The P-selectin may be still expressed, and the defect is in either NBEAL2 and or the GFI1B genes. Now, the Quebec platelet disorder, it is a very rare condition where there is a gain of function duplication mutation in the urokinase type plasminogen activity, that is the UPLA gene, that causes hyper activation of plasmin, and that degrades the clots. And what happens is that there is enhanced activity of total the fibrinolytic activity is enhanced there, and you can get you can diagnose it by measuring the total platelet UPA activity. And the defect is in the UPLA gene that causes the Quebec platelet syndrome. Now again, this table gives a bird's eye view of the different disorders and the defects associated with the different platelet counts and the responses to different platelet agonists. Now here, okay. So now this table shows the disorders which can have normal platelet count and abnormal aggregation. Now what these are the disorders that we saw, but this is just put in the tabular form for a quick review. Now the disorder where you get normal platelet count and normal aggregation, that is the Scott syndrome, that is the procoagulant activity that is defective there. Thrombocytopenia, small platelets and platelet dysfunction that you can see commonly in Wiskott-Aldrich syndrome. Thrombocytopenia, giant platelets and platelet dysfunction you can see in Bernard-Soulier syndrome or platelet type von Willebrand disease. Now, these instruments you saw in the laboratory yesterday, that's the ROTEM. Now, these are more importantly useful in a hemostatic laboratory when it comes to identification, particularly of the fibrinolytic disorders. Because for till clot formation, you can do all the investigations individually. But for fibrinolytic disorders, the ROTEM or the TEG, now ROTEM is more sensitive than the TEG. That is what we have found when it comes to identification of the fibrinolytic defects. Now, these are some of the data of NIIH, what we have seen or what we see regularly. So generally in a year, we get about 570 patients referrals for with mucosal bleeding for a possible platelet function disorder diagnosis. Out of that, we get about 4% Glanvill's thrombocythemia, 0.7% Bernard-Soulier syndrome, and about 7% of them turn out to be von Willebrand disease. But the rest are still uncharacterized. That's a big number. So we have recently we did a study which is now almost to completion, where we did or analyzed all these unclassified platelet function disorders. And to our surprise, we found that about 30% of these patients had a mutation in a gene called RAS-GRP2, which causes defective platelet secretion and activation. Now, overall in the literature, the number of cases in RAS-GRP because of the defect in RAS-GRP2 was very low. That is about 20 to 24 mutations only were reported till 2019. And here we had in just one series of patients about 30 to 40%, 30% of cases we got in RAS-GRP2. So that goes to say how much unexplored are our cases of rare disorders, and they may not be as rare as they occur in worldwide literature because of the unique population groups that we have. This we recently published in the British Journal of Hematology. Now, apart from that, we have been doing diagnosis, molecular diagnosis of neonatal alloimmune thrombocytopenia, and we have diagnosed several cases of NIITP because of incompatibilities of various human platelet antigens. And that brings to the conclusion of my talk. Thank you very much. So, if there are any questions.
You mentioned that for the confirmation, we need to go for flow cytometry. Can we directly go the flow cytometry exam?
If the clinical suspicion is high on GT, yes, you can go if you don't have the aggregation. Now, one important feature of GT is that there is a defective clot retraction. Just if you don't want to, I mean, if you just want to do something before you go for flow cytometry, you can look for the clot retraction. If there is no clot retraction in 1 hour, then you can have a very high suspicion of GT, then you can directly go for flow cytometry after that. If you don't have aggregation, or if you don't want to do it for some reason.
On flow cytometry, how to identify platelets?
So we can gate the platelets separately. So what we are doing is we are using PRP. So it's only single population that we have. So it's very easy there. But even then, even if you use whole blood, you can gate the platelets and then you can study them. Yeah.
One question, can you please elaborate regarding ristocetin and its use in different functional disorders?
Okay. So ristocetin sulfate, now for two of the most common disorders that are diagnosed, that is von Willebrand disease and Bernard-Soulier syndrome. In these two situations, you get abnormal aggregation induced, ristocetin induced platelet aggregation. Now here the problem is not in Bernard-Soulier syndrome, the problem is with the receptor itself. So you don't get APDT derangement, even though you don't get aggregation with ristocetin sulfate, APDT is normal if it is a case of Bernard-Soulier syndrome, whereas in von Willebrand disease, the problem is not with the receptor, the problem is with the von Willebrand factor. So you get, along with nil ristocetin aggregation, you get a prolonged APDT with factor VIII deficiency.
The next one will be explained in maths.
Yes. So we have a dedicated lecture by Dr. Jasmeena Ahluwalia, madam. So she will be talking exclusively on von Willebrand disease. Thank you.